welcome all my friends over here in India as well as abroad, and welcome to this 97th episode of the continuing medical education program that's being organized by Andhra Medical College since August 2020. And as you know that we are reaching towards 100, and we wanted to do 100 of these episodes. And I'm very glad that towards the end we thought that we should have a recap of what's happening in the last 1.5 years or so. So we have invited Dr. Mohammad Adrish, who has been a regular speaker on this forum, who presents very explicitly, and he is very comprehensively, he deals with the subject and puts everything in the proper perspective. That's why we thought that we will have him once again, so that we will brush up all our knowledge. And when the third wave is imminent for India, as it appears in the month of January and February, I feel it's very appropriate that we brush up our knowledge. And to moderate this particular session, Dr. Gontapalli, a very popular and highly experienced critical care specialist, is there. So I request her to take over and introduce Dr. Adrish for the sake of all those people who have joined for the first time. And I request her to moderate and take this forward. Thank you very much.
Thank you, Dr. Sudhakar, and congratulations to you and Dr. Kairam and Dr. Chilamuri for successfully. I mean, it's not just doing like a 2-day conference. This has been a huge marathon for you, what we call a ultrathon, where you run for 100 miles at a stretch. So congratulations, and I'm really proud of your efforts. It has been a Herculean effort to keep going for 100 days of conferences. It's my pleasure to introduce Dr. Mohammad Adrish, who is well known to this group. Dr. Adrish, we stole him from Dr. Chilamuri's hospital, Bronx Care Hospital from New York, recently, maybe in July or so of this year. So he has been with us for about a few months now. And he's an associate professor in pulmonary critical care and sleep section. We work in the same hospital. And I have actually seen him prior to even him joining here through your conferences. So I knew what we were getting actually. And he has been a lot more than what I heard him here in these conferences. He has been a very distinct pleasure to work with. And he's not only his knowledge and patient management, but he's a very wonderful person to work with and very easygoing and excellent member of our faculty. That Dr. Guy will also agree with me. And he has been very active in the national organizations such as American College of Chest Physicians, American Thoracic Society, and he holds a number of leadership positions, and he's really a rising star in our specialty. And I'm very happy that he has been so involved in these conferences. And he's going to, I guess, give a recap of what our experience has been and what the recommendations are in various critical care aspects. Dr. Adrish.
Thank you, Dr. Sudhakar, and thank you, Dr. Gontapalli, for this opportunity. I'm going to share my screen. Can you see my slides?
Yes, we can see.
Okay. So I'll be going over some of the updates in the medical management for COVID-19. Some of the information that I'll present here may be a repetition, which I will use to tag on to some of the new information. I don't have any disclosures relevant to this presentation. We'll be briefly going over some updates in the antivirals, steroids. I'll talk both about systemic as well as inhaled steroids, JAK inhibitors, IL-6 inhibitors, anticoagulation, monoclonal antibody treatment, mode of Auxin delivery, and rescue therapy. As you can see that this is a packed session. I'm going to be briefly touching those topics with some other very relevant studies. I may not be able to cover every study in each of these topics. So if I miss something, I apologize in advance. So some of the therapies that have been recommended against use by IDSA as well as NIH guidelines are hydroxychloroquine, azithromycin, lopinavir, ritonavir combination, convalescent plasma, famotidine, ivermectin, colchicine in hospitalized patient, IVIG in acute COVID, except for the use in kids who have these inflammatory syndrome and interfere or severely or critically ill COVID patients. So these are the topics that I will not be touching during this presentation. I'll start with remdesivir. We all remember this trial, Act 1, May 2020, our first drug trial that was done and published in COVID-19. The trial did not show any difference in mortality, but there was a reduced recovery time, 10 days versus 15 days, and the benefits were greatest in the patients who were randomized early in their illness, which is consistent with how the antivirals work. Followed up another trial published by Spinner in September of 2020. This trial looked at 10-day remdesivir course versus 5-day remdesivir course. In this trial, there was improved clinical status on day 11 in 5-day remdesivir group compared to standard of care, and there was no difference between the 10-day and the 5-day group. So that's when the 5-day remdesivir became standard of care. Goldman published the data again in November 2020. Again, this is a comparison of 5-day remdesivir and 10-day remdesivir. Clinical status was similar between the two groups. Mean duration of hospitalization was also similar between the two groups. There were higher serious adverse events that were noted in remdesivir group, 35% versus 21%. So again, 5-day remdesivir has been what we use in most of our patients. Subsequently, at the end of last year, a Solidarity trial data was published by WHO. In this, there were multiple arms in this trial. The remdesivir arm had about 2,700 patients, and they compared this group with the standard of care, where patient did not get remdesivir. However, these patients are on multiple other therapies at that time, which included hydroxychloroquine and lopinavir, ritonavir groups as well. And in this study, in-hospital mortality was similar between the two groups, and initiation of mechanical ventilation was also similar between the two groups. Discovery trial is something that just came out 2 months ago. Again, in this discovery trial, just like Solidarity trial, they had 5 groups, including placebo, remdesivir, interferon, antiretroviral, and hydroxychloroquine. These patients were symptomatic for more than 7 days and required oxygen support at the time of enrollment. In Discovery, again, they did not see any difference in outcome, just like Solidarity trial. But again, these two trials were not very clean, crystal clear trial like Act 1 trial, where there were only 2 groups, patients who were getting remdesivir versus those who were not getting remdesivir. And finally, we just got the data from Act 3 trial, where interferon beta 1A was used in combination with remdesivir. It did not show any improvement in time to recovery. However, there were increased serious adverse events in patients who were getting interferon beta 1A. So again, this is something that has been discouraged in combination with remdesivir. So coming up on the guidelines, remdesivir is recommended by IDSA for patients who are on supplemental oxygen but not on mechanical ventilation or ECMO, and they also recommend 5-day treatment. They recommend against using this drug in patients who are not on oxygen or patients who are not on invasive ventilation or on ECMO. If you look at the NIH guideline, per NIH guideline, remdesivir is approved for COVID-19 in hospitalized adults as well as pediatric population aged more than 12 and weight more than 40 kilos. So again, NIH guidelines have been much more liberal with the remdesivir use, so they don't differentiate with the severity of illness, whereas IDSA kind of goes into more detail as to which patient would likely to benefit from remdesivir use. A couple of new antivirals which are now coming out. This is molnupiravir. This is what Merck recently published data on from MOVE-OUT trial, which was a non-hospitalized adult patient with mild to moderate COVID-19. These patients had symptom onset within 5 days of randomization. By day 29, 77.3% in molnupiravir arm were either hospitalized or died, compared to 14%. So almost 50% reduction in hospitalization or death rate with the use of this drug. There were 0 deaths in molnupiravir and 8 deaths in placebo group in this study. Adverse events were similar between the two groups. They also noted that molnupiravir demonstrated efficacy across viral variants, including Gamma, Delta, and Mu strain. So after these data, they have stopped the study recruitment. This drug was already approved by UK on November 5th, An FDA meeting, which is US regulatory authority, is slated for November 30th to discuss the emergency use approval of this drug in the United States. The second drug that came out, the data came out recently, was from Pfizer on Paxlovid. This is a combination of PF 07321332 agent in combination with ritonavir. So this agent blocks the activity of SARS-CoV protease, which is an enzyme that the coronavirus needs to replicate. And they combine this with ritonavir, which kind of decreases its degradation, so kind of boosts it, just like it is used for boosting in HIV regimens. All these patients were also treated within 5 days of symptom onset. So these are again non-hospitalized adult patients with COVID-19 and are at high risk of progression to severe illness. Patients who got treated within 3 days of symptom onset, Paxlovid arm had 3 out of 389 hospitalizations with no death, versus placebo arm, which has 27 hospitalization with 7 deaths. Patients who got treated within 5 days, Paxlovid arm has 6 deaths out of 600, again about 1%, versus placebo arm, which is 41 out of 600, which is about 7 to 8%. The adverse events were comparable between the two groups. So again, very favorable data from this study also. So they have also stopped recruitment, and the data is submitted to FDA for approval. Talking about systemic steroids, the landmark trial on systemic steroids was a recovery trial that was published in July 2020, where patients received dexamethasone plus standard of care versus standard of care alone. 28-day mortality was 22% in DEXA arm and 25% in standard of care arm. This was statistically significant. However, there was no survival benefit in participants who did not require oxygen therapy and enrollment. And this is what we have been also emphasizing in our previous meetings, to use these medications only in patients who have required oxygen. Med-COVID arm looked at methylprednisolone and use in severe or critical ill patients. In Med-COVID trial, there was no difference between the groups in early mortality and day 7 or need for mechanical ventilation by day 7. But when they looked at subsequent subgroup analysis, patients who were older had lower mortality when they received methylprednisolone versus placebo. We just got data from COVID steroid 2 study, which looked at higher versus low dose of dexamethasone. So they compared 12 milligram dexa with 6 milligram dexa for up to 10 days. And the primary outcome was day alive without life support. And here they saw a mean difference of 1.3 days, which was in favor of 12 milligram dexamethasone. However, this did not reach statistical significance. Mortality on day 30 also had low relative risk for 12 milligram dexamethasone, but again did not reach statistical significance. Similarly, mortality day 90 also had 0.87, but did not need statistical significance. So statistically speaking, there was no improvement in mortality with higher dose of dexamethasone. However, in this study, serious adverse reactions, including septic shock or invasive fungal infections, were similar between the two groups. And this is the data, this is the graph from this study. As you can see, the time to death at 90 days. There is a nice separation between the two graphs with non-statistically significant p-value. So maybe a larger study could have gotten some difference statistically, but again, this is essentially a negative study statistically speaking. Inhaled steroids, I'm going to present 2 studies over here. First one was TOIC that was presented earlier in this year in April. These are the patients, adult patients who had COVID symptoms for less than 7 days. So this is an open label study because you cannot, hide the inhaler. So they did not use placebo inhaler. They used budesonide twice a day until symptom resolution plus usual care versus usual care alone. The primary endpoint was COVID-19 related urgent care visit, including ED visits or hospitalization. And this was 1% in budesonide arm and 14% in usual care. So there was about 91% relative risk reduction. And this was the graph from the study. Probability of clinical recovery was much higher in budesonide compared to usual care arm. Second study that just came out a couple of months ago was Principal Trial. This trial was done on patients who were 65 or older, or patients who were 55 or older with comorbidity. So again, patients who were at high risk of progression to severe illness. These patients were unwell for up to 14 days as opposed to Stoic trial, which where the cutoff was 7 days. They suspected COVID-19 but not admitted to hospital. These patients received inhaled budesonide, usual care alone, or other treatments. Again, in this study, time to first self-reported recovery was 2.9 days versus 11.8 days, favoring use of budesonide. Hospitalization, 6.8 versus 8.8%, even though the odds ratio is 0.75. The confidence interval crosses 1, so not statistically significant here. This is the data on cumulative recovery. As you can see here that these two groups, the group that received budesonide had higher recovery compared to the ones who did not receive budesonide. So what do the guidelines say? IDSA and NIH both recommend steroid use in hospitalized patients with severe or critical disease. They recommend against using steroids in non-severe patients. These are our patients who are either on home without home oxygen or patients who are in the hospital and not requiring oxygen. NIH guidelines also recommend using in outpatients with new or increasing need for oxygen requirement. This is especially true in resource-limited situations like we had in our last wave, where we may not have enough beds for our patients. So these patients can benefit from steroids even in an outpatient setting. With regards to inhaled budesonide use, NIH has not commented whether for or against its use. So again, I presented the data to you. If you want to go in more detail on the data and want to make a decision, you can do that. But again, for the guidelines, it's not recommended at this time. Talking about JAK inhibitors, the first data came from Hapkovic Trial, which was a 1,000-patient study randomized 1-to-1 to receive baricitinib daily for 14 days or placebo, both with remdesivir. So by that time, remdesivir was already a standard of care. They noted a shorter recovery time of 7 versus 8 days when they received baricitinib, and non-statistically lower mortality at day 28. What we need to know about this study is that it did not use steroids, which was our biggest criticism of this trial. That maybe when you use steroids, baricitinib will not work. This was further evaluated in Hapkovic Trial, which was a 289 randomized to vasodilators, which is another JAK inhibitor at a dose of 10 milligram or placebo for up to 14 days. In this study, almost 90% got steroids. What they noted was cumulative incidence of death or respiratory failure was 18% in vasodilators group versus 29% in placebo group, so about 10% reduction, absolute risk reduction, and succeeded adverse event were similar between the two groups. And finally, we got this data from Cough Barrier Trial, which was published a couple of months ago. Here we had about 1,500 patients who received baricitinib or placebo for up to 14 days. They excluded patients who are on mechanical ventilation. So this is something that we need to note. Maybe not, so this study does not apply to ventilated patients. A lot of these patients were using steroids. About 20% was also using remdesivir when they used baricitinib. So there were a lot of patients who were using baricitinib without even using remdesivir. There was no difference in disease progression. However, 28-day mortality was about 8% in baricitinib arm and 31% in placebo arm. There's a nice separation that you see here in the placebo versus baricitinib group, so lower mortality in baricitinib group. And again, this is statistically significant. Adverse events were comparable between these two groups. So what do the guidelines say? The guidelines recommend using JAK inhibitors in adults with severe COVID-19 who have elevated inflammatory markers. These patients should not receive tocilizumab or other IL-6 inhibitors if they are receiving JAK inhibitors. NIH recommend JAK inhibitors for patients who require Auxin delivery through high flow or non-invasive ventilation. So again, for NIH, it is a slightly higher threshold, whereas IDSA, you can use it even in patients who are requiring supplemental oxygen. Talking about IL-6 inhibitors, here again, our main data source is Recovery Trial, which was published back in May. They included patients who were hypoxic and had signs of systemic inflammation. About 2,000 patients received tocilizumab, another 2,000 received usual care. A lot of these patients were receiving steroids during the study. 28-day mortality was 31% in tocilizumab group, 35% in usual care group, which is relative risk reduction of about 15% over here, which is statistically significant p-value. Most discharges by day 28. in TOSI group, which was 57 versus 50%. So again, not only lower mortality, but a lot of these patients got discharged also from the hospital. Again, because here patients were on steroids, what they noted was that with tocilizumab, there was an additive effect in addition to steroids. So when they were given along with steroids. DMAP-CAP was published in April. This was done on critically ill patients who were receiving cardiac or respiratory organ support. So cardiac support would be using inotrope or vasopressor. Respiratory organ support would be somebody who's on non-invasive or invasive positive pressure ventilation. 335 patients received tocilizumab. In some centers, they use sarilumab, and rest of the patients got standard of care. They found that organ support-free days were much longer in patients who got tocilizumab and sarilumab compared to standard of care group. 90-day survival was also higher with a hazard ratio of about 1.6. Serious adverse events were similar between the tocilizumab and standard of care arms. So again, as we are always concerned about using tocilizumab and having serious adverse event, in this trial they did not see that. COVID talk is another study that was done recently, but what they studied in this cohort was patients who were having both moderate as well as severe disease. So these patients were not as sick as patients in the recovery trial or even DMAP-CAP trial, which was even the sickest of these two trials. Here, when they used tocilizumab, they did not see any difference in disease progression. However, there was lower decreased progression in a subgroup analysis of patients who had severe disease, 16% versus 34%, which is statistically significant. So again, these studies point of the role of IL-6 inhibitors in patients who have more severe illness. And finally, this Karim-Ansari trial that was published in January 2021, these patients were also moderate to severe disease requiring at least 3 liters per minute oxygen. 68 patients got sarilumab, 80 got usual care. Day 14, 37% in sarilumab and 34% patients in usual care group needed ventilation or diet. So pretty similar, outcome. Serious adverse events were also similar between these two groups. So again, no difference in outcomes with regards to need for ventilation or death. Also similar serious adverse events. So what do the guidelines say about IL-6 inhibitors? IDSA recommend IL-6 inhibitors in adults with progressive, severe, or critical COVID-19 who also have elevated markers of inflammation. They recommend using sarilumab. The 311 patients were in therapeutic arm, 304 were prophylactic arm. Primary efficacy outcome, again, similar between the two groups. Major bleedings were much higher in therapeutic arm compared to prophylactic arm. So again, just like Inspiration trial, Action trial was also a negative study. Then this data from multi-platform, which is a combination of PAC, Active4, and DMAP-CAP. They published 2 studies, one on moderately ill patient, and the other one was on severely ill patients. So these are the critically ill patients, and these are the non-critically ill patients. So in non-critically ill patient, therapeutic dose was superior to prophylaxis with regards to organ support free days. And they also noted a very low major bleeding rate over here, which is less than 2%. However, in the severe group, therapeutic anticoagulation did not improve organ support free days at day 21, and major bleeding risk was higher, almost double when they looked at the difference between the two groups. So you can see here is about 3.7%. So again, this is a positive study for using therapeutic anticoagulation in non-critically ill hospitalized patients with COVID-19. We just got some updates on Michelle trial from ESC Congress. This trial is done on patients who were discharged after their hospitalized stay. And these are the patients who are at increased risk of venous thromboembolism. There are several times this question has been asked on this forum regarding whether we should do post-discharge VTE prophylaxis. So here is our answer. So these patients were at increased risk of VTE. They had higher improved score, either 2 to 3 with elevated D-dimers or more than 4. I'll go over about on improved score in a bit in my next slide. What these patients got was rivaroxaban 10 milligram once daily for 35 plus minus 4 days versus no intervention after a hospital discharge. So these are at high risk of VTE. based on the score. And what they saw was there was 64% reduction in composite outcome of symptomatic VTE, VTE-related death, and detected VTE. So these are the patients who were diagnosed with VTE. They did not see any difference in major bleeding. So again, we are still waiting for the final published trial, but again, this has been published online, and this was presented in ESC Congress very recently. Two more trials that I want to present here on anticoagulation is RAPID trial that was published last month. These are non-ICU hospitalized patients with high D-dimer. 228 patients got therapeutic and 237 patients got prophylactic anticoagulation. There were similar composite outcome of death, invasive mechanical ventilation, non-invasive mechanical ventilation, or admission to ICU between the two groups. However, when they just looked at the death, that was much lower in patients who got therapeutic anticoagulation versus prophylactic anticoagulation. And this is the graph from that study. Here you can see that death from any cause is 1.8%, which is right here. So this is odds ratio is favoring the use of therapeutic dose versus prophylactic dose, which is 7.6. Another major concern in patients who receive therapeutic dose heparin is intracranial major bleeding. So here this line is crossing 1, so non-statistically significant difference between the two groups. It is 0.9% in therapeutic heparin, prophylactic heparin is 1.7%. ICU admission is also not different between the two groups, and primary composite outcome, as I mentioned here, is not different between the two groups. And we also got Hapkovic Trial, which was also published around the same time, and the RAPID trial was published. This is again similar study, hospitalized adult patients with COVID-19 with D-dimer levels more than 4 times the upper limit of normal, or patients who have sepsis-induced coagulopathy score of 4 or more. These patients got either standard dose or therapeutic dose. Primary outcome of thrombosis or deaths was a much was different in patients who are not in ICU compared to those who are in ICU. So again, here major bleeding risk was higher in patients who are on therapeutic anticoagulation versus prophylactic anticoagulation. So this is the patient with over here you can see the graph of proportion of participants with primary outcome. These are the therapeutic dose heparin, which is about 41%. Standard dose heparin, which is about 41%, and therapeutic dose low molecular weight heparin, which is about 28.7%. So again, relative risk of 0.68, therapeutic dose anticoagulation. So again, more data supporting the use of therapeutic dose anticoagulation in select subgroup of hospitalized adults with COVID-19 who are not in critical care setting, or who are not critical here. So what do the guidelines say? Guidelines say from NIH, they recommend avoiding prophylaxis in non-hospitalized patients. Prophylaxis to be given in hospitalized patients, and continue extended VTE prophylaxis after hospital discharge for patients who are at low risk of bleeding and high risk of VTE. So this is a new update. They also recommend systemic anticoagulation in patients who are highly suspected to have thromboembolic disease. When we look at the American Society of Hematology guidelines, they recommend using standard dose thromboprophylaxis in hospitalized patients with preference given to low molecular weight heparin. They recommend against the routine use of post-discharge prophylaxis, but can be considered in high-risk patients who have a higher improved DD score, which I'm going to present in the next slide. And in November update, they also mentioned that moderate DL patients be carefully considered for therapeutic dose anticoagulation with a determination of individual in the absence of objectively confirmed VTE. So again, this is probably based on the most recent data that came from Hapkovic Trial and the MET trial that was published in the last couple of months. And I was mentioning about improved DD score. So this is the improved DD score. So there are risk factors, previous VTE, known thrombophilia, current lower limb paralysis or paresis, history of cancer, ICU, CCU stay, immobilization for more than 1 day, and age more than 60 years. All of them are assigned a number, and then you calculate the number. If the number is 4, or if it is 2 or 3 with an elevated D-dimer more than 2 times the upper limit of normal, the study showed that these patients had VTE event rate at day 35 of about 8% versus 2.8% who have lower scores. So again, if your patient has cutoff score higher, these are the patients who may benefit from extended prophylaxis after the hospital discharge. Monoclonal antibody, we have 3 monoclonal antibodies that we are using. First one is region curve, which is data was published back in September 2021. COVID-related hospitalization or death was 1.3% in patients who received region curve versus 4.6% in placebo. Also, they had shorter time to symptom resolution. They did not see any increased adverse events with this monoclonal antibody. Blaze-1 looked at bamlanivimab and atezolizumab within 3 days of positive SARS. Here, 2.1% of the patients in BAM group had COVID-19 related hospitalization or death, as compared to 36, which is 7% in placebo group. They also looked at the viral load with bamlanivimab as atezolizumab therapy, and they saw a reduction in viral load as well with this therapy. And finally, we just got the data from COMET-ICE, which is sotorivimab group. Sotorivimab, here patients, 290 patients got this therapy versus 290 in placebo group. There was about 85% relative risk reduction with the use of sotorivimab therapy. So these are all the therapies that are being that are done in outpatients who have increased risk of progression of COVID-19. So IDSA and NIH guidelines are same in their recommendation for neutralizing antibody. They recommend in patients who have mild to moderate COVID-19 and at high risk of progression to severe disease. They suggest using bamlanivimab and atezolizumab, or casirivimab or mdivimab, which is the region-cov combo, or sotorivimab therapy in these patients. I'm going to go over a couple of trials in mode of Auxin delivery. Usually we use nasal cannula when these patients require oxygen, then we escalate to high flow nasal cannula, and then we sometimes go on to give them non-invasive positive pressure ventilation or intubate these patients as their oxygen requirements increase. So there are some recent data that was published on that kind of bypasses some of this standard of care that we're using. So I'm just going to present the data over here. So this was Heniward trial published in March. This is a study from Italy. As we saw also on CNN, they were using a lot of helmet positive pressure ventilation. So they published this data from their experience. So these patients were receiving helmet for at least 48 hours, followed by high flow versus high flow alone. The settings that they used was PEEP of 10 to 12, pressure support of 10 to 12, and FiO2 about 50%. And they have, these are the rest of the settings over here. So what they saw was that the patients who received this helmet therapy, they have higher day free of respiratory support. The endotracheal intubation rate was also lower in patients who got helmet therapy. Inpatient hospital mortality was not different. So even though the helmet reduced the likelihood of intubation, it did not affect the hospital mortality between the two groups. Recently, Recovery Respiratory Support Trial published its data on MedRxiv. So again, this is non-peer reviewed, just like all the other recovery trials data they first published there, because this data is of interest to general public, so that everybody can read it. So I'm sure this will be published in the next few weeks, if not next few months. So they looked at about 1,272 patients across 48 hospitals in UK. These are the adults with SpO2 of less than 94%, despite using FiO2 of 40%. So again, kind of getting close to maybe requiring higher level of care or higher level of respiratory support. These patients had symptom onset of about 9 days. They used CPAP in 377 patients, high flow 414 patients, and conventional oxygen therapy in 368 patients. As you also note here, a lot of these patients had crossover. 15% had crossover in CPAP therapy, so these patients could not tolerate CPAP. 11% had, did not tolerate high flow and had to cross over to the other group. And this crossover was about 23% in conventional arm. But as this is an intention to treat analysis, so they still analyzed all these patients within their respective group. When they compared CPAP with conventional oxygen therapy, the odds ratio for intubation was much lower, 0.72, a p-value of 0.03, so almost 28% reduction in need for intubation. However, when they compared high flow in nasal cannula with the conventional oxygen, the odds ratio for intubation was not different between these two groups. Again, just like the Hapkovic trial, even in recovery RS trial, there was no difference in mortality. CPAP group also had lower need for ICU and had a longer time to intubation. So they took a long time before they got intubated. Safety events were higher in patients who got CPAP compared to high flow or conventional therapy. There were about 8 serious safety events, of which 7 occurred in CPAP group. So again, that is something that we need to watch for. So some of these safety events that they mentioned was hemodynamic compromise or patients who develop barotrauma and pneumothorax. Again, another thing was that was very remarkable in this study is that there is no way you can blind the investigator. So if somebody's on CPAP or high flow versus conventional oxygen, people will know what they are getting. And often the decision to intubate is depends on the provider. So it's not something that is controlled by the trial investigator. So if it's a provider discretion, if he feels like his patient needs intubation. So again, when you view these data, you might want to have that perspective in your mind as there is no difference in overall mortality. So what do the guidelines say? The guidelines, NIH guidelines recommend that adults with COVID-19 and acute hypoxemic respiratory failure, despite conventional oxygen therapy, they still recommend using high flow nasal cannula over non-invasive positive pressure ventilation. And this is from our experience with ARDS population in general, patients who have non-hypercapnic hypoxemic respiratory failure even before COVID-19 happened. And patients who adults with COVID-19 and acute hypoxemic respiratory failure for whom high flow nasal cannula is not available, in the absence of an indication for endotracheal intubation, we can give a trial of non-invasive positive pressure ventilation. And as you saw from the studies that I just presented, you need to watch these patients closely because the safety concerns with non-invasive positive pressure ventilation use, but you may be able to prevent some of the intubations in these patients. A couple of studies on rescue therapy. So APP meta trial looked at awake proning. This is an open label randomized controlled trial on patients receiving high flow nasal cannula. 567 patients received proning, 559 standard care. Probability of survival without outcome, as you can see here, was much better in patients. So intubation was much lower in patients who received proning. Mortality was not different between the two groups. So again, patients who get prone, less likely to get intubated, but again, mortality is not different between the two groups. CORD did a subgroup post hoc analysis of this trial. They divided patients with early prone positioning who got prone within 24 hours of high flow nasal cannula versus late prone positioning who had like a median of 36 hours before they got prone. So here the median duration was about 2 hours. And what they saw was that there was a signal towards improved mortality, no difference in intubation rate. So this is the graph from that study. So as you can see here, patient who got intubated within the first 11 hours versus the patient who got intubated within the first 24 hours, 36 hours, more than 36 hours, so the hospital mortality not nicely, but goes up as you delay awake proning in these patients on high flow nasal cannula. So maybe a signal there that on using awake proning early on in patients who are requiring high flow nasal cannula rather than delaying the proning in these patients to get maximum benefit. NIH guidelines for patients with persistent hypoxemia who require high flow oxygen and for whom endotracheal intubation is not recommended. The guidelines recommend awake proning. They recommend against awake proning as a rescue therapy for refractory hypoxemia to avoid intubation because you don't want to delay intubation when it is indicated. Inhaled vasodilators, there's a couple of observational studies I want to present here. So this is the study that looked at use of inhaled epoprostenol and inhaled nitric oxide. What they found were there are two groups of patients who benefit from use of this therapy. So about half of these patients are responders where you would see some improvement in oxygenation. There are other half who would not show any improvement. Similar data was seen in the study by Rajiv Sonti, where there are patients who have improvement after using inhaled epoprostenol, where some other who do not have improvement. However, there was a median change that was net positive 9 millimeter of mercury in improvement on oxygenation status in these patients. There are two ongoing trials, VP COVID and ILO COVID, which are looking on use of inhaled vasodilators in COVID-19 patients. But for now, patients who are severely hypoxemic, you have an option to use inhaled vasodilators in these patients to see if they respond. And if these are your responders, maybe you can continue inhaled vasodilators, whereas if your patient does not respond, maybe those patients you want to stop these medications early. So with the NIH guidelines, the panel recommend using inhaled vasodilator as a rescue therapy. And if there is no improvement in oxygenation, the treatment should be tapered off. Recruitment maneuvers, there are no studies that have assessed the effect of maneuvers on oxygenation in COVID-19. We have this data from LOFT trial back in 2008, which was a negative study, essentially when they used lung open ventilation model. Gallagher did a meta-analysis in 2017, where it looked at about 6 trials and saw the outcomes in these patients. In this meta-analysis, this found reduced mortality, which is about 0.8, improved oxygenation, and decreased need for rescue therapy. And this meta-analysis was the reason for the guidelines that were made by NIH. So the NIH panel recommends using recruitment maneuver as a rescue therapy, then not using it. And if these maneuvers are used, they recommend against using a staircase maneuver, which has been shown to be associated with barotrauma. SCCM guidelines also recommend traditional recruitment maneuvers in patients who are hypoxemic despite maximum ventilatory support. Intubation timing has a lot of controversies, and this remains controversial. The 2 studies, opposite result, DUPIA study, higher mortality in early, Bavishi study, early intubation, lower mortality. This was the meta-analysis that was published in March of 2021. 12 studies, about 9,000 patients, no difference in all-cause mortality, no difference in duration of mechanical ventilation. And this is the graph here, as you can see, that this is crossing 1. So again, no difference, maybe favoring late group, but again, statistically, this is insignificant. So again, intubation timing, it really depends on patient circumstances. And the guidelines do not address intubation timing as well. These are all the references that I used, and I'm happy to take any questions.
I don't see any questions in the chat box. Let me ask you the first question. Since we work very much in the ICU, you see a patient who's on high flow nasal cannula or just got intubated in the ICU, who's paralyzed, neuromuscular block paralysis, because patient is in acute severe hypoxemic respiratory failure. What would be your orders on mechanical ventilation, or supportive care, anticoagulation, all of these? Because your improved DD score would be at least 3 or above.
Right, so improved DD score is, so anticoagulation is something that has been studied in critically ill patients, but so far we don't have high quality data that has shown anticoagulation to be beneficial in these subgroups. And these are the patients who also the data shows that these patients have high risk of bleeding. So I think it kind of balances out in the end, which is why we are not seeing a mortality benefit in these groups. So unless I am suspecting, just like in any other patient, if I have a patient who's hypoxic and I'm worried that this patient has pulmonary embolism and the patient is sick enough that I cannot take this patient for an assessment. So this is somebody who maybe I do an ultrasound and I see that the RV looks pretty big, or they have signs of RV overload, such as IVC dilatation, or the chest X-ray does not correspond with the hypoxemia that they're having. So those are the patients who are very hypoxic, but again, not stable for me to assess them with the CAT scan. So these are the patients where I will still use anticoagulation empirically until I can effectively rule out that diagnosis. But otherwise, I would stick with my prophylactic anticoagulation in these patients.
Would D-dimer come into your equation? or catheter, any of the central lines or any blockage of those. I mean, these are the
Yes.
practical ones we have seen, right, at bedside.
Right.
So,
Right. So those are exactly the indications. So those are something other than. So like the other day, I was admitting a patient, and I was, we were going to do a CAT scan on that patient, and they wanted a 20 gauge IV line. So I started ultrasounding the patient, and on my ultrasound, I saw that in sphenic vein patient has a blood clot. Even though it's a superficial vein thrombosis, that's an indication that this patient is developing clot. So I started that patient on anticoagulation. Another patient we had, where patient had on CRRT for renal failure, and patient's line kept clotting. And this was a patient who did not have a diagnosed PE. Yet the patient was on full dose anticoagulant. So there are certainly those patients who will have COVID-19 and have some sort of either suspicion or some suggestion that this patient may be having thrombosis, and they would benefit from anticoagulation. What I'm trying to say here is I want to discourage everybody coming to ICU and getting anticoagulation, because
even
that is
therapeutic.
not therapeutic anticoagulation, because that is something that has not been shown to improve survival in these patients.
What about other orders? Proning, paralysis,
Yes.
vasodilators. If you're writing orders on this patient, what would you write?
Everybody gets prone. I usually, if somebody is early on in their illness, or I do not know how long ago the illness started, so I'll give them benefit of doubt. And if their kidney function and liver function is fine, I will also start them on remdesivir. I will also start them on IV steroids. Most of these patients get dexamethasone unless they have reasons to go on hydrocortisone, or somebody is having wheezing and I want to give something of higher intensity. Maybe they have underlying asthma. But most of these patients go on dexamethasone. Other thing that most of these patients get is some sort of either JAK inhibitor or anti-IL-6 therapy. So if we have enough supplies, we will go with tocilizumab if these patients have rising inflammatory markers. If they don't have elevated markers, we can use or we don't have tocilizumab therapy, we can use baricitinib in these patients as well, even though some of the guidelines discourage using baricitinib in patients who are on mechanical ventilation. Those are some of the therapies. What else? All of these patients will get prone as long as they can, tolerate it and can do it safely. So most of our patients in the ICU will be prone with COVID-19 and severe ARD, especially those who have PF ratio of less than 150 or even close to 150. We will watch our fluid management on these patients. So after the first 24 hours when they are resuscitated, we'll go conservative fluid management. If they're developing renal failure, they will receive some sort of renal replacement therapy depending on what is available to support their organ functions.
Thank you.
Sorry.
I think I see Dr. Buddharaju, who is professor of hematology in University of Nebraska, raising his hand. So he may want to chip in for the anticoagulation piece.
Yes.
The anticoagulation, I think American Society of Hematology itself, the guidelines are not very definitive. They're basically leaving it up to the clinicians, I think, to decide.
Correct.
So I think that's what we're doing too. But I had a question for all of you who are seeing so much of COVID. In Midwest, we're seeing rising cases, both because of unvaccinated people getting infected and also waning immunity in vaccinated people, especially who got vaccinated very early in December, January last year. So we're also seeing increasing hospitalizations of fully vaccinated people. Is that what you're seeing too in New York and Texas? Because that would have implications, because India is probably lagging behind in vaccinations by a few months. And so the question is, what are the regulatory authorities in India deciding on, based on what data to give boosters to Indian population or not? That would be important to know, I think.
Yeah, we do. We saw a fair number of vaccinated patients also, but they were much smaller in number compared to patients who were not vaccinated. I don't have the data from our hospital, but certainly think that the data that has been published from other places, there's a kind of like 90 to 10 discrepancy in patients who are non-vaccinated getting admitted to the hospital versus patients who are vaccinated getting admitted to the hospital. We see a fair number of these patients in the floor, but coming to the ICU, those are predominantly are non-vaccinated patients, younger patients. A lot of them were younger patients. A lot of them had underlying comorbidity. So a cohort that was protected in the first and second wave, like a young patient with asthma, or a young patient with obesity, or I had a patient like a 24-year-old who had a renal transplant, but unfortunately not vaccinated, was extremely sick, was in the ICU for almost 2 months, almost died. Those are the patients that we are seeing in the ICU, unfortunately now.
Yeah, I think
Actually,
from what I'm hearing,
from our hospital.
Yeah.
You are muted.
We do have data from our hospital. I'll share the slide as soon as I find it. It is very small percentage, but most of the patients we've been seeing is unvaccinated patients.
So I'm just wondering what prompted the FDA to so quickly issue a call for boosters for all adults. And I think part of it was rising numbers of vaccinated people being hospitalized, and also what they're seeing in Europe. And the data from Israel, I think, is very strongly suggestive that, especially with Pfizer, that the immunity is waning to the point where vaccinated people are getting more sick. So I don't know, maybe Prem Kumar can answer this, and if they have data with breakthroughs with the Covaxin and the Covishield, and if they are actually planning on a booster program.
So, Madam, can I talk?
Yes, Doctor.
Yeah, please go ahead.
Good evening, Dr. Adrish, and good evening, ma'am. And at the outset, congratulations, Dr. Adrish, for your excellent exposition. And you have, cut the clutter and very patient review of literature. Now everything is clear. But I have one thing in my mind that belongs to our regional practice. So regarding this monoclonal antibodies, we are giving casirivimab, imdivimab cocktail. But the problem here is the indication is, within 3 days, maybe extended to 7 days in asymptomatic people with high risk groups. But here in India, people, once they get the symptoms of viremia, that is fever, myalgia, headache. But the symptoms of viremia, you mean asymptomatic, are symptoms of hypoxia and respiratory failure. I understand the symptoms of hypoxia and respiratory failure. But here in our setup, people come to us with CT scans. The 3rd day, 5th day, 7th day, whenever they approach us, a lot of people, they come to us and ask for monoclonal antibodies. But by the time I see the CTs, let it be taken on 5th day or 3rd day, some GGOs are noticed here and there. So how to go about this? So here, there in US, probably they don't do the CTs so early in asymptomatic people. So we consider them as asymptomatic, and it is easy for us to give monoclonal antibody thinking that they're asymptomatic. But here, though they are asymptomatic as far as respiratory failure or hypoxemia are concerned, their CTs are showing diffuse GGOs here and there. How to go about with monoclonal antibodies? They come to us for monoclonal antibodies along with the CT abnormality.
So here in New York, I had experience, like first-hand experience with monoclonal antibodies. At least I was involved with the group that was doing it. So over there, we were kind of using all sorts of symptoms. So if somebody has respiratory symptoms, fever, cough, they may not have hypoxia, they may not have shortness of breath. Because many of the time when these patients get hypoxic, if there is a bed available, these patients are in the hospital, which is where we don't use monoclonal antibodies on these patients. So for these patients, as long as they are early in their illness, we would still give them monoclonal antibodies. What these studies show, and again, we still have to see what the real world data show, is that the risk of serious adverse events is quite similar between the two groups. There is a risk for anaphylaxis with any antibody cocktail that you're going to give to this patient. Again, there are a lot of other antibody therapies that we also give. So if the patient is on the cusp, like 5 days, 7 days, and have some symptoms, and patient belongs to that high-risk group, like patient is old or has comorbidities, we would, sometimes, even if they are on the cutoff, just below the cutoff, we would still give them benefit of doubt. But if somebody is like, let's say, coming like after 10 days, or somebody is hypoxic and really needs to go to the hospital, that's the time when they're probably past the viremia phase, and the monoclonal antibody may not help. Just like we saw with convalescent plasma, that there was a signal that may benefit very, very early in the illness, but later on in the illness, it was probably not going to help.
But asymptomatic patient with CT abnormality within the window period.
So, so symptomatic patient got CT for some symptoms. Nobody would just go and get the CT scan. He had something that prompted him to get the CT.
Basically, patient
just because somebody else was getting CT and he also had to get CT, then that's a different story. But if you had, let's say, fevers, I think that's a symptom.
Here the problem is patients will have fever and myalgias, and people who are affluent or who are very much concerned, they go straight away and get a CT. So the fever, myalgias are there, and he doesn't belong to a high risk group, but comes with a CT abnormality.
Yeah, so then that's the group where if the patient does not belong to a high risk group, that's where we
but
need
CT
to
CT abnormalities are there.
Yeah, so CT abnormality is still COVID-19, right? So if somebody has COVID-19 and does not belong to a high-risk group, like the one I mentioned, does not have an immunocompromising condition, does not have diabetes, is not old, those are the patients that, all these trials, did not study, excluded. So again, there is no data that these medications will help them. So that is what I would explain to them. And in India, Pakistan, the situation is that if you don't give it, they'll go and get it from somebody else. So they're just going to do window shopping till they find a doctor who's going to give it to them if they have made up their mind. So unfortunately, you can counsel on your side, but again, if it comes down to you making the decision. If patient is young, no risk factors, only symptom is like an abnormal CAT scan, I don't think that patient would benefit from monoclonal antibody therapy.
And Dr. Adrish, are you sticking to that 6 mg dexamethasone dose, or even for huge obese people? Recently, I had a few people who are weighing around 120, 130 kgs, or you will go by 0.1 milligram per kg. Like.
So most of our patients are on 6 milligram. We have tried 12 milligram on few patients. Dr. G probably has a lot more experience on this with me. I just presented you the data from COVID Steroid 2 trial. There was a signal of maybe some improved outcomes in patients who got 12 milligram versus 6 milligram. I think in the next maybe a month or two, somebody will do a post hoc analysis and will publish which group benefits from that higher dose of therapy. So I don't have that answer for you as of now. I would probably stick to my 6 milligram dose for now, as long as I get more evidence.
Thank you, Dr. Adrish.
May I say something about that?
Yes.
Yeah, Dr. Guy, go ahead.
Elizabeth Guy. So one thing that we observed in our most recent surge is a lot of infections. And they were bacteremias, a lot of pneumonias, a lot of gram negatives. And so I personally would hesitate to give the higher dose dexamethasone or steroids until the data is strong enough to tell us that, sure, there is a benefit, but who are the patients that are getting the side effects of the infections? I believe it caused a lot of morbidity and contributed to mortality that we saw in our ICU in our most recent surge, which was just this summer. It was very noticeable. Not that we used higher dose steroids, we actually used the tocilizumab and baricitinib as our additional therapeutics in our patients during this surge.
I suspect that it is because of the co-use of toci or baricitinib, because there is pre-COVID ARDS studies, pretty large number, 400 patients in each group, that showed benefit of higher dose, 20 milligrams of dex, first 5 days and 10 from day 6 to 10. So I think it is a concomitant use of other medications that we have not used in ARDS in the past that is causing the co-infections that we saw in this surge. If I may share the slide, I can just show you the data from our hospital. Can you see it?
Yes.
Okay, let me see why it's to one side. Okay, I don't know if you can see this slide.
Yes.
This is our Harris Health System from January 1 to August 30th. And as you can see, the number of patients is 1,566. And the death rate was 9.6%. And the people who were fully vaccinated, it was only 2%. Partially vaccinated, 4%. Most of the deaths were in unvaccinated. And the non-deaths, again, mostly unvaccinated patients. So although we did see some breakthroughs or, of vaccinated patients, most of them are unvaccinated patients.
Madam, excuse me to come in. How this vaccination is reducing the mortality? Normally, this mortality is related to cytokine storm and all those things. How is this vaccination is meddling with the immunology?
I mean, they're not getting as severe a disease, or they're not getting it, even in our own group, several fellows and faculty did get COVID who were fully immunized, but we are exposed on a daily basis, and none of them required hospitalization. So I think the severity of the disease is much, much less.
Madam, may I ask a very simple, fundamental question? Now that we have more and more people getting these breakthrough infections, and particularly in those individuals where it has been more than 6 months that they have got the second dose, that means the antibodies are waning off. So they are turning positive, but totally asymptomatic, and they're getting tested for various reasons, that they are in a crowd or they got exposed to some other people, so on and so forth. In those individuals who are those who are asymptomatic, how far should we investigate? They're asking what next that need to be done. They're asymptomatic. The only thing is that they're positive. Should we go and investigate them? If so, to what extent and when?
I don't think if they're asymptomatic or they just have a fever and, if they just come to be COVID positive, sometimes people are getting COVID testing pre-travel. For example, international travel, people are getting, they have to get a test and they turned out to be positive, totally asymptomatic or very mild symptoms. I don't think you need to investigate any further. You can advise them. We do have clinics on the private side of advice for such patients. So they tell them to monitor their oxygen saturation and so on. But I don't think you need to get CT scans and all of those. What do you think, Dr. Guy?
I agree. If they are minimally symptomatic or asymptomatic and they are vaccinated, monitoring themselves, of course, self-quarantine is the #1 recommendation. But I personally, because our work is in the ICU, we do not see the outpatients or patients who are minimally symptomatic. So we go by what we believe. We don't have experiential information to tell you. But I agree 100% with Dr. G, not to do further investigation unless there are other symptom-driven manifestations.
Yeah. Thank you.
Dr.
And
Adrish has to leave. Dr. Adrish has to leave. Any questions for him before he leaves, or?
One last question: at what point you consider tocilizumab? Are you still based on IL-6 levels, or it is only CRP and acute oxygen requirement, enhancement of acute oxygen requirement?
So first you have to have a deterioration, some sort of, somebody comes to you, 3 liter oxygen sitting stable, no change. That's not the patient who should get tocilizumab. So somebody has to have some sort of deterioration, either in the chest radiography or increasing oxygen requirement, plus any inflammatory marker, whichever your system has available. If you don't have IL-6, you can check ferritin, you can check CRP, as long as you can see a rise in one of those inflammatory markers. That would be somebody that I would consider for IL-6 inhibitors.
If inflammatory markers are not rising, but oxygen requirement is enhancing,
then it's a tricky situation. Then I'll use my steroids and maybe repeat markers in 12 hours and see what happens. I have not used IL-6 inhibitors on similar patients in the past. Again, so these are where we don't have data. So those groups, again, sometimes you would use it, sometimes you won't use it. So then you would look for a lot of different things. What is the risk of infection? What am I going to gain with it if somebody doesn't have any inflammatory markers? Am I going to get any benefit on these patients? So again, that's kind of an individualized situation at that time.
Thank you, Dr. Adrish. Thank you so much.
Thank you so much. I would have to excuse myself.
Yeah, sure.
Meeting Dr. Guntupalli and Dr. Guy. Thank you so much for coming. And I think you can continue, but I'll just turn off my screen.
Thank you. Great job.
Thank you.
I hope
So
you
one
don't
thing
have a.
to say, in our hospital, the use of tocilizumab or baricitinib requires approval from infectious disease. So they are our, if there is no sign for increased inflammatory markers, they generally will not approve it. That's not to say everything that Dr. Adrish said is correct, like individualize it. There's a deterioration, but no inflammatory markers.
Thank you.
Dr. Buddharaju, I want to pick your brain. I keep asking our hematologists because I can't get any definitive recommendations from them. Because everybody is very clear on prophylactic, very clear on VTE and PE. We know what to do. It's the gray zone. Because some people in our group are very aggressive. They'll go for full anticoagulation, even TPA. If they see acute right heart failure, we can take them down to CT scan and patient is really deteriorating and we can't find another explanation. What is your, what are your thoughts?
So in our group, we have similar differences. Some of us are very conservative, and unless there's enough documentation or enough high degree of suspicion for a thromboembolic event, we're generally, not going, therapeutic anticoagulation, primarily because I've had some bad experiences with bleeding, especially in the ICU setting. So I think overall it kind of balances out, like the study's point. And so at that point, it becomes very, very individual and patient-based, clinician deciding basically which way he wants to go. But certainly, the bleeding risk is there. I mean, I think in our institution, I don't have the exact numbers, but it's probably in the 6-7% range when we use full dose therapeutic anticoagulation, especially in the real sick patients. So I've gone the conservative route, and unless there's strong evidence for thromboembolism, I've generally not recommended. I've been pushed to recommend, but basically, either way is okay, I think, as long as you accept the increased bleeding risk in this population.
Yeah, a lot of times at bedside, we feel like we are pushed to make the decision and we end up making it. right or wrong, a lot of times it's not evidence-based, it's experience-based, which is the last two patients you saw who got better or who got worse or who bled or who did not bleed or we did have patients with intracranial bleed and, thoracic bleed and various things. But, at the bedside, when you're there, patient is dying in front of you and you see acute RBF on ultrasound or, bedside echo, you're pushed, we can't, they're on 3 pressors or something, we just can't take them down. So we end up doing whatever your prejudice is or your last two patient experience.
Yeah, a lot of our ICU doctors have become less reliable on our recommendations because a lot of times with our consultations, at the end of the consultation, it's hard to figure out what the hematologist is recommending, to anticoagulate or not to anticoagulate.
Yeah, I can never get anything out. I mean, I wanted something in writing. I can't get anything. Dr. Guy, anything you want to share your experience in the third surge, how it was different than before?
Our most recent surge came upon us very rapidly. There was a very rapid uptake of young patients as young as I think 28, maybe 30. We lost, and their lungs were very stiff. And then when we intubated them, it was really hard to oxygenate and ventilate them. I clearly remember several who I expected may have, lingered several weeks to the point where we might be able to trach them, but it was a refractory hypoxemic respiratory failure, which was, I would say, in the first wave, we did not really see. That would be my distinct recollection of this most recent surge. We did have a few that were vaccinated who succumbed, and they had like a rheumatoid arthritis. One had a achalasia. He was fully vaccinated, but he had achalasia. We had invasive aspergillosis as a complication of one of our patients, this one who succumbed. So I felt that this last wave, Dr. Guntapalli, was more traumatic for me because I felt quite helpless, despite the fact that I had hopes that baricitinib or tocilizumab was gonna save the day for several of them, but it didn't. We did have many VTE events also, though.
Yes. So that's why it's so difficult. We have to be monitoring these patients, although, because we now are seeing them for weeks, so just because I didn't have on a CTPE, 2 weeks ago, doesn't mean they don't have it now. So
yeah.
One of the things is whether we should be looking for DVTs like on daily morning rounds or something like that. We don't know.
Yeah. Yeah, we sometimes would see it in the internal jugular. As soon as you put the ultrasound, oh, there it is. The clot is there. Or you're gonna put a femoral line. Oh, there you see a clot in the leg, in the femoral vein. So we had seen a few of this.
I mean, I think it's more than a year now. We have a post-COVID clinic, and we have been seeing a number of patients, not just post-COVID, but also in our pulmonary clinic. And I would say most of the times, maybe 50-60% of the time I can discharge them because they've recovered and they've gone back to work, and we do a 6-minute walk test and make sure they're not desaturating. But I have not seen in like 40 years, this many number of tracheal stenosis, tracheomalacia, and things like that, airway related problems, because these patients, although many of them may be totally normal before they got ARDS, but these patients are on prolonged mechanical ventilation, they're paralyzed, they're prone. And so I at least 5 or 6 tracheal stenosis that require dilatation or a tracheostomy below the level of the stenosis are pretty serious interventions. We have had at least 5 of those patients, which I have not seen in such a short period of time in all these years.
That's
And
true.
we've had some of them have still residual lung disease, and some young patients have pulmonary fibrosis, and hoping that it'll improve. So I think you in India will, with the large numbers that you have, I'm sure you're going to have these problems, probably on a larger scale in India. And I don't know what the recommendations are. Do we give antifibrotics, or when do we wait? How long do we wait? Do we give steroids? We've had a number of patients who got better, went home and came back, or went to the floors and came back. And the infiltrates that got better now look worse. So we treat them as COP, cryptogenic, pneumonitis, and we treat them with steroids, higher dose of steroids like Solumetrol. And we've seen some good results. What do you think, Dr. Guy?
We have seen a few improvements, yes, for sure. But I would say that they are not, the ones who get better and then go to the floor and come back, they're relatively few and far between. But yes, there has been a few that I would say we gave the steroids again and actually improved them.
Higher dose, yeah, and longer time.
I asked Dr. Guntapalli about her experience with the long COVID. I was just reading before we came on just to prepare. So the long COVID, they are saying it's 10 to 30% of survivors might have long COVID. And I was wondering what your experience in India is, because I would hazard to say that maybe the mortality in India was higher compared to mortality that we are seeing here. But among the survivors, there may be long COVID. And according to the descriptions that I was reading, it's quite devastating, the patients who suffer from long COVID.
I don't know, maybe Dr. Prem Kumar or somebody is doing the post-COVID clinic. I don't know if you're seeing, fatigue seems to be the most common and very prolonged fatigue.
Yeah, not yet, madam. We have not launched a formal post-COVID clinic, but every day in my regular practice, I have been seeing a lot of patients post-COVID. Most of them, they come for fatigue. A lot of people, they come for breathlessness and residual interstitial fibrosis. And a lot of people complain of diffuse chest pain. In spite of adequate investigations, they reveal nothing. And a lot of people are depressed. But we have seen a lot of cavities in post-COVID, and after doing bronchoscopy and BAL, most of them reveal Klebsiella cavities, and some of the cavities are of Aspergillus. And I've come across mucor in 1 or 2 cases, but a lot of Klebsiella cavities and Aspergillus cavities post-COVID.
The other thing we have seen in this clinic is we do it with psychiatry faculty that is with us. A lot of depression, anxiety, depression, a lot of psychiatric, almost 50% of them. These are like patients who are not even hospitalized. So I think that may be the next epidemic of psychiatric problems post-COVID.
If I may chip in.
Yeah, please.
Yeah, if I may chip in, my name is Bush Kavuru, and I was able to do a small survey within Andhra Pradesh. And I think a couple of weeks ago, I was here sharing some of that information. As Dr. Prem Kumar already mentioned, and as Dr. Guntapalli mentioned, a lot of people are complaining of hair loss. Most of them are women, and severe fatigability, and associated with depression, anxiety, and insomnia, up to 30 to 40% of them. And we also had people with headaches and palpitations, and some of them with the chest pain. I was able to get a Google survey, and that's the sample within the family and the friends. Just I wanted to share that. Thank you.
Yeah, I think the psychiatric issues maybe, we've seen some palpitation and some autonomic issues and, requiring referrals and so on. But the two major other thing I have seen, maybe that may be because of the high BMI that we see generally here, is I have picked up a lot of obstructive sleep apnea, almost I would say 25-30%, partly because some of them have gained weight because of lack of activity, fatigue, and so on. Otherwise, I suspect that maybe they would have never come to a physician if they didn't have COVID. So that was another comorbidity that I was able to pick up, quite a few actually.
If I may, I just had one question for Dr. Guntupalli and one for Dr. Sudhakar and Dr. Prem Kumar. Do we have data on a 1-year survival or maybe even 18-month survival for COVID-19 hospitalized patients who ended up being on high flow oxygen or mechanical ventilation? How many of them are actually alive at 12 months or 18 months? Do we have that data at all? Or the second question was for Dr. Sudhakar. Does ICMR have any data about breakthroughs, and are they coming up with any policy about boosters since they've crossed 100 crore vaccinations?
Yeah, with regards to your first question about the survivors after 12 months, I don't think there is any structured data in that regard. Nobody is perhaps collecting the data. With regards to the second one, the ICMR, it has not come out with the booster dose for the simple reason that the second dose has not been completed for most of the people. In the sense that more than 50% have to have their second dose. So unless they have this second dose completed, the government is not going to come back, I suppose. That's the reason why not even for the health workers, they are promoting the booster dose. So that's the situation over here.
Dr. G, do we have any data in US about a 12-month or 18-month survival on these patients who were really sick and survived ICU admissions and mechanical ventilation?
I don't recall. We are just looking at ours. We only have maybe like 300 or 350, at least ICU patients. I'm trying to remember. Dr. Guy, do you remember if we had any?
No, I have not seen anything in the published literature about them. What I have seen was the long COVID, and which was what I was reading, but I have not seen, although we have not systematically searched. I think that is an important thing to look at as you have planned, Dr. Guntupalli, about studying all the survivors. And
I think the PETAL network and some of the ARDS type of networks, the PETAL networks, I think they're looking at it. I don't know if they're published.
Yeah.
Dr. Sudhakar,
even in ARDS, even pre-COVID ARDS patients, the 1-year survival and 5-year survival data, if you look at it, it's shockingly small number of patients. They will show like 100 patients follow-up. And how many do we see over? This is pre-COVID data. So it's not, sorry, you were saying something.
Yeah, I was asking Dr. Sudhakar if we can actually look at that data prospectively on people, at least in KGH and Chest Hospital and WIMS and Vizag, and see if how many of them actually are alive at, say, 6 months and 12 months. And that would be important to know, I think.
Yeah, good idea. Probably we'll have a telephonic conversation with them and try to find out as to how they are doing, because we have the phone numbers of most of the patients who were discharged from the hospital. It's a good idea to do that.
One point Dr. Bush Kavuru made about hair loss and things like that. Any critical illness you will have, because the growth kind of stops. So we'll see lines on the nails, and I can tell if they were admitted 3 months ago or 4 months ago, any critical illness like septic shock or, patient who had chemo, whatever. And hair loss also in patients who are critically ill, not necessarily COVID. If they were in the ICU or critically ill, they will have the hair loss. So I think we are out of time, Dr. Sudhakar.
Yeah, ma'am. Thank you very much. And let us wind up the session. And thank you very much for so ably conducting these proceedings, and for Dr. Adrish for an excellent presentation as usual. And Dr. Gai for your input and your expertise has added value to this particular discussion. And Dr. Prem Kumar, Dr. Buddharaju, thank you very much. And Dr. Kaya, we are missing Dr. Kairam because he's on travel. I spoke to him a few minutes before we started this program. However, he has been very instrumental in scheduling this particular program today. And of course, Dr. Sridhar Chilamuri was also not there, but still he is also contributing very significantly. We'll have 3 more episodes to go towards 100. We are fast approaching 100. After that, probably we'll rest the case. And after that, we will do as per the requirement once we have the 3rd wave or impending 3rd wave. And whenever we want some discussion, please stay on and please be obliged to participate in future also. Thank you very much, madam. With that note, I conclude this particular session.
Thank you.
Thank you, ma'am. Thank you, sir.
Good night.
Thank you. Good night.